Your strangest fear may be far more ordinary than you think. But before we rank the phobias people actually live with, there is one trap. A fear is not automatically a phobia. Being cautious around a cliff or a venomous snake can be rational. A specific phobia is intense, persistent, out of proportion to the real danger, and powerful enough to trigger avoidance or disrupt daily life. That distinction changes the ranking completely. Internet lists count anything with a Greek-sounding name. Researchers count patterns that meet diagnostic criteria. In the United States, the National Institute of Mental Health estimates that about 9.1% of adults experience a specific phobia in a given year, and 12.5% experience one at some point in life. Across countries, the exact order moves because culture, environment, age, and survey methods all matter. So this is the most honest ranking. The 5 major families clinicians use, from the less commonly reported categories to the one that repeatedly rises to the top. At number 5, the other category. It sounds small, but it contains some of the most disruptive fears: choking, vomiting, loud sounds, costumed characters, or situations that do not fit anywhere else. The prevalence is difficult to compare because it is a catch-all, and that is exactly why it belongs at the edge of the ranking. One person may avoid restaurants because of choking. Another may plan an entire day around the possibility of vomiting. The trigger looks unusual. The avoidance pattern does not. Number 4 is blood, injections, and injury. Needles, dental procedures, blood tests, wounds, and hospitals can all sit inside this family. It also has a biological twist. Most phobias push the body toward a racing heart and rising blood pressure. Blood injection injury fear can produce a 2-stage reaction. Alarm first, then a sudden drop in heart rate and blood pressure that may cause fainting. That is why just look away is not always enough, and why avoiding a routine test can become more dangerous than the needle itself. Number 3 is situational phobia. Think airplanes, elevators, tunnels, bridges, trains, driving, or enclosed rooms. The feared object may be perfectly safe, yet escape feels impossible. This category often hides inside practical explanations. I prefer the stairs. I hate traffic. Or flying is too expensive. But when a person turns down work, travel, or medical care because the situation feels unbearable, preference has become a cage. Flying and confined spaces are among the most frequently seen examples in clinical samples. Number 2 is the natural environment family. Heights, deep water, storms, darkness, and other forces that once carried obvious survival value. These fears can feel especially convincing because the brain can point to a real hazard. A balcony is not imaginary. Lightning is not imaginary. The phobia appears when the alarm becomes wildly larger than the present risk. When a photograph of a high place, a weather forecast, or even imagining a bridge can trigger panic and avoidance. And number 1, across a large international population study, is the animal family. Its cross-national prevalence was about 3%, although the estimate varied substantially by country. Spiders are famous, but snakes, dogs, insects, mice, birds, and other animals can become the target. The surprising part is that direct trauma is not required. Some people remember one frightening encounter. Others learn fear by watching a parent react, hearing repeated warnings, or absorbing a cultural story. And some cannot identify a beginning at all. So why do public speaking and social judgment seem even more common? Because they belong to a different diagnosis. Social anxiety disorder centers on scrutiny, embarrassment, and negative evaluation, not one specific object or situation. Agoraphobia is also separate. It involves fear of places where escape or help might be difficult if panic-like symptoms occur. Mixing these conditions with specific phobias creates dramatic lists, but it destroys the meaning of the numbers. There is another reason rankings are slippery. Many people have more than one phobia. A person who fears flying may also fear heights in enclosed spaces. Surveys can count that person in several categories, so the percentages cannot simply be stacked into one perfect pie chart. Age matters too. Animal and blood injection injury fears often begin earlier, while some situational fears emerge later. And access to treatment changes what clinics see compared with what community surveys find. The real winner, then, is not one monster, needle, or airplane. It is avoidance. Every time avoidance brings immediate relief, the brain receives a powerful lesson. Escaping kept me safe. That relief rewards the escape, and the fear gets fewer chances to update. The next encounter can feel even more dangerous. That cycle is also why specific phobias are treatable. Evidence-based treatment commonly uses carefully planned, gradual exposure, approaching the feared cue in manageable steps, long enough for the brain to learn that anxiety can rise and fall without catastrophe. It is not about throwing someone into their worst nightmare. It is structured practice, often guided by a qualified clinician, especially when fear causes fainting, severe panic, or major disruption. Your fear does not need an exotic name to be real, and being common does not make it harmless. The better question is whether it is quietly choosing your routes, appointments, relationships, or opportunities for you. Which fear did you expect to rank higher? Subscribe for more hidden patterns your brain never explained.